I'm doing a shoulder talk. You guys already got a really good one from Javernick this morning. A little bit of this will be review, but the big goal of this talk, and as we get into it, is more what is normal in the shoulder, what's concerning in the shoulder, and when should you be sending stuff off to be considering more surgical type stuff. This is giving me a little feedback, so I'm just going to speak up and move it away from me. Who do we have in the room? Do we have therapists, doctors? We got PTs? How many PTs? I've talked to a few of you guys. Great. OTs, any hand therapists? Great. I'm sorry I'm not talking about hand, but shoulder is important, and OTs still do some shoulder, but I do love the hand. I'm one of the 4 guys that does hand and fingertip and all the there will be blood stuff, but I also love the shoulder. And I, as much as Dr. Chamberlain said, the shoulder is the most important, or the hand's the most important thing in the world. The shoulder puts the hand in space too, so it's all important. If you can't reach anything, you can't do that much with your hand. So it's all important. Do we have docs? Any PCP docs? Perfect, great. And students? Anybody else? Anybody that's just learning? Great. Great. If you guys have any questions as we go, feel free to interrupt me. This is supposed to be a little more casual than the big conference room, and hopefully just a little bit more interactive. So objectives, like we talked about, kind of improve your understanding of common pain generators within the shoulder. There's a lot. Explain the natural history of rotator cuffs. So Dr. Javernick got into this a bit, but kind of talking about what's the normal aging process of the shoulder and what's really a problem and what's not. And then just try to improve appropriate triage of rotator cuff pain. Any therapist is going to see a ton of shoulder pain, primary care doctor, ER, any of that sort of stuff. It's just super duper common, so it's a big part of it. And I think one of the biggest parts of shoulder is that the MRI is very much a Pandora's box. And there's no way you can get an MRI, even if you're a young, healthy 30 or 40-year-old, and not end up with 7 new diagnoses that you didn't know you had before. And as much as I enjoy taking care of shoulders, one of my more frustrating parts of the job can just be education to patients on what all of that actually means, because it all sounds very big, bad, and scary when they get their report on their cell phone app. So. Common diagnoses within the shoulder, all sorts of things can be pain generators: impingement, bursitis, rotator cuff tendinopathy, tearing, obviously arthritis, the AC joint and scapula, underlying glenohumeral joint, frozen shoulder, fractures, instability, really just a lot of different things that can happen. It's a complex anatomy. This is just a couple pictures here showing the long head biceps, which is a common pain generator within the shoulder, coming up within the shoulder. This is a kind of a cool picture showing what the healthy rotator cuff looks like if you take it off at the musculotendinous junction, and you can see it really actually works more like a drawbridge, where it has this rotator cable that helps share the load of the rotator cuff. And then the big thing is just how a healthy rotator cuff really starts right at the edge of the articular cartilage, and helps work with that force couple. The acromion can be very different in different patients. Most people are kind of this type 2 with a little bit of a spur, and obviously impingement lesions and kind of that sharp beaking in the acromion is another possible cause of issues. The rotator cuff is a sleeve of 4 muscles around the shoulder, and a view of the front of the scapula with the subscap. The subscap is the biggest and strongest of the 4 rotator cuff muscles, and it's kind of the forgotten one. Everybody thinks about the supraspinatus, where the vast majority of tears are, but certainly subscap shouldn't be overlooked. The supraspinatus is above the acromial spine, and then you got the 2 more posterior rotator cuff muscles, the infra and the teres. All 4 of those together are really a sleeve of tissue. And they blend into each other. You don't see really where one starts or one stops. And in conjunction, they help with this force couple, which as Dr. Javernick had mentioned, when the deltoid starts to fire, the rotator cuff helps pull the head into the socket. The socket's really shallow. I tell people this is like a kind of a basketball on a golf tee sort of situation, where you got a really big ball and a small joint, and it's easy for it to fall off, and you can really see why young athletes are commonly dislocating their shoulder, and why the shoulder is one of the most commonly dislocated joints, because there's not a lot of inherent stability between the bones, and it's the rotator cuff pulling and creating this force couple that really helps create that stability. And it's a relatively thin sleeve of tissue that does not have great blood supply, so over time it can commonly fail. If it does fail, sometimes it doesn't cause any issues at all. Sometimes it causes pain and eventually can get to the point that it can cause weakness. In the worst situation with a rotator cuff tear, you have something called pseudoparalysis, where you have a very large tear, and even though your deltoid's working, all your muscles and nerves are working, you cannot lift your arm up overhead. And so it looks like somebody's paralyzed, but it's really just complete dysfunction of their rotator cuff. There are patients with massive rotator cuff tears that can lift their arm overhead like nothing's wrong, though, and we don't really understand why some people are able to still lift their arm and compensate for really large cuff tears, and other people are left completely incapacitated with their shoulder. When you look at an MRI, and this is just getting into some of the things that can happen over time with a rotator cuff, a relatively small tear like this up here looks like nice healthy tissue. This is a chip shot from a surgical standpoint, meaning that pulling that tissue down to bone is probably going to go well, and you probably have a relatively young patient and have a good chance of getting that to heal. This is not so much of a chip shot, so this is looking from the outside in. This is the articular cartilage here, and this is just a large retracted tear. You're seeing the biceps tendon up in the front, and the larger the tear is, the more chronic or degenerative it is, far more difficult to fix from a surgical standpoint. The longer tears are there, the more the muscles can change as well. So this is one of the more common MRI views that we look at when we're evaluating patients, and I tell patients this looks like a ribeye because you're looking from the side. But what this is a scapula. You're looking at the scapula from the side, and so you can see this Y shape, and you see the muscle bellies of the different rotator cuff muscles, with the subscap in the front, the supraspinatus in the top of the Y, and then the infra and teres kind of blending together in the back. And the longer the tear is, this person has great muscles, and you come into kind of the worst case over here where they have way more fat than muscle. And in a situation where somebody has more fat than muscle, the likelihood that a repair is going to help that person, that you're even going to be able to get the tendon back, gets more and more difficult with time. So, and a couple other of the MRI views that this is actually a acute on chronic tear, and kind of shows you how they can look when they're degenerative versus when they're acute. So this is more of a degenerative tear. This is a humeral head sitting on the glenoid. We're looking at it kind of from the front to the back, and gray muscle turning into black tendon over here. And on the left, you can see how this just turns into thin, frayed, wispy tissue, versus on the right, where you can see this looks like healthy tissue that's almost kinked and waved. And so if you have a healthy rope and you pull and break it, it's still going to look like a healthy rope, and it's going to look like it's just kind of springed back. If you've had a rope that's slowly thinned and frayed over time and then finally gave up, it's going to look a whole lot thinner and crummier, and it's going to have a different look to it on MRI. This is actually all within the same patient. So if you look at the muscle belly here for the supraspinatus, this has a lot of fat replacing muscle, and so a lot of white that's replaced the muscle over time. And if you look at the infraspinatus, the muscle belly actually looks really healthy. And so this is the acute portion of the tear, and then the supraspinatus is likely something that's been there for a long time. So a person's allowed to have both. They're allowed to have a tear that was degenerative and starting, and then they did something like try to help their son move their couch and had a stumble and felt a pop and kind of extended a tear, and ended up with more of an acute on chronic tear. What are the big things not to miss, and when should you get an MRI? I think that if anybody's had a major acute trauma to their shoulder, getting an X-ray is an easy thing to start with. It's astronomically cheaper than an MRI. You can rule out any sort of dislocation or fracture, and just get an initial assessment whether they have underlying arthritis. Sometimes we're surprised by all those sorts of things. The only thing I really consider urgent in a shoulder is a young patient with a full thickness rotator cuff tear from an acute injury. And so if you have a 40-year-old patient, going to hit this a little lower, that had a dislocation, or somebody who had a really major trauma to their shoulder and has an inability to lift their arm overhead, that is a reasonable thing to get an MRI on. If you're in your 50s or 60s and felt some pain, but you're still able to lift your arm overhead, I think that's more in the realm of what you can treat non-operatively on the front end and see if it does improve before you jump down the road of getting an MRI and all the things that can open up. The most clear indication for me is when people dislocate. So if you're young and healthy and you dislocate, more likely to have a labral issue. If you're over 40, way more likely to tear your rotator cuff when you dislocate your shoulder. And I routinely get an MRI right out of the gate even a few days after an injury if somebody's had a dislocation within that age group. Most people, if they come in their 50s and 60s and they're concerned, but their x-rays look good and their pain is intermediate, meaning they do have pain with loading, but it was a relatively acute injury, but they're still functioning reasonably well, I'll give them a chance to cool off. And I'll say, we can try some anti-inflammatories, we can try some exercises, we can see how you look in a month. A month isn't going to change things dramatically from the repairability, and then bring them back. And if they're still having significant weakness and concern, then kind of going down the road of getting the MRI. Things that should always be treated conservatively first is gradual onset of pain. If there wasn't an acute event, an acute pop, a sudden change in function or strength, anybody over the age of 65, unless it was a really striking injury, should likely be treated conservatively first, because we're far more conservative on the surgical side, so getting the information may not be all that helpful. If they have known arthritis, almost always it's more likely that it's an arthritis flare or something that's kind of flared up the underlying degenerative joint. And then if the patient's a poor surgical candidate, sometimes you just have to take a big step back and say, this is a concerning event, but I know we're not going to do something because you've just had a big open bypass surgery or something else that just makes somebody not in a situation where we really could do a surgery. And therefore getting more information doesn't necessarily change what we were going to do to begin with. So to take a big step back, what's normal? And you have to put all this in perspective when making decisions about, one, whether to get imaging, and two, whether to do anything surgically. And this was a nice study done out of Harvard in 2014, where they basically looked at the prevalence of rotator cuff disease as people got older, kind of get a look at what was normal within the shoulder. So they reviewed over 30 studies, over 6,000 shoulders, and compared symptomatic to asymptomatic shoulders as people got older. This is a really, really busy table, but this is basically what it comes down to. In that your rotator cuff abnormalities as you age are striking, and by the time you're 80, you're expected to have a rotator cuff tear. So I tell people almost every day in clinic that rotator cuff tears are like gray hairs in aging, and if you live long enough, we expect you to have one. That's what your shoulder's supposed to do eventually. And that's the reality of it, is that over 50% of people over 80 are going to have a degenerative rotator cuff tear. It is not normal for a 50-year-old to have a rotator cuff tear. And so all of the abnormalities that you see on MRI have to be put in context with how old the patient is. And so by the time you're 60, 65, about 1 in 5 people will have a rotator cuff tear. By the time you're 75 to 80, it can be almost half of people. So those are the people that you need to be more conservative, because you're really, in some ways, fighting the aging process more than treating a true anatomic abnormality that needs to be fixed.
Less than 20, is that because it's higher than 20?
Yeah, that's a good question. I think it's probably that there's way less number of patients. I bet there's like 10 patients under 20 who have a shoulder MRI. And I bet they all either had a dislocation or high-level sports or that sort of thing, for sure. I think seeing the bump there is probably related to that. And the summary of this paper was really that the prevalence of rotator cuff abnormalities in asymptomatic people is high enough for degenerative rotator cuff tears to be considered a common aspect of normal human aging, making it difficult to determine when an abnormality is new or the cause of the symptoms. And so sometimes the MRI is just showing you their anatomy and not necessarily showing you what their true pain generator is. This is another great study that I often am quoting to patients, and this is a study where they took patients who came in with complaints of shoulder pain, and they got an MRI of both shoulders, and they said, what's different between the two? And they had radiologists and orthopedic surgeons look at both MRIs and kind of categorize what was wrong within the shoulder. So 123 patients with intermittent shoulder pain, unilateral. They excluded neck pain, adhesive capsulitis, people who had any complaints in the other shoulder, any major prior trauma. This is a relatively young age group, so it's only 40-year-old average age, plus or minus 15 years. So this isn't just 65 plus patients either. And so in the scheme of shoulder abnormalities, this is really relatively young, healthy people with good function, still having the ability to lift their arm overhead. Rotator cuff tendinopathy was present in 92% of symptomatic patients and 88% of asymptomatic shoulders. Partial thickness tearing was equivalent, no statistical difference. Full thickness rotator cuff tearing was the only thing that broached statistical significance as far as the difference between the asymptomatic shoulder and the symptomatic shoulder. AC arthritis, 90% of patients, everybody has arthritis at the end of their clavicle. Seeing some early fatty infiltration, 1 in 5, and labral abnormalities, which are almost always overcalled slap tears. Almost every, well, not almost every, about 50% of shoulder MRIs are read with slap abnormalities or some sort of labral degeneration, called in the exact same number between symptomatic and asymptomatic. This is surgeons reading it instead of an MSK radiologist. Still equivalent. The rates of tendinopathy, partial thickness tearing, essentially the same between the symptomatic asymptomatic group. Full thickness tears, far more common in the symptomatic group. Glenohumeral arthritis was more common in the symptomatic group with the surgeons reading the advanced imaging. So really, what does this tell us? Only a full thickness rotator cuff tear and arthritis is predictive of an abnormality that's different from the other side. So if you have a patient that comes in with rotator cuff tendinopathy and they're very fixated on it and they feel like it needs a surgery to mechanically change their shoulder to fix it, that's probably a little bit misguided as far as the front line. And I often reassure people, especially people who have not had a significant duration of symptoms, have not gone to therapy yet, have not tried an injection, that if we looked at their other shoulder, more likely than not, it would look exactly the same as that side. And that often can calm people down because they're frustrated. Shoulder pain is notorious for keeping people up at night. When you have people who are sleep deprived and in pain, they want a quick, easy solution. And unfortunately, there often is not one. And I also often am reminding people that surgery is definitely not a quick, easy solution when it comes to the shoulder.
Their other shoulder is just as bad as the shoulder that they're worried about is reassuring.
Yeah, it's not saying that it's as bad. It's actually saying that it's either as good or just that it's the same, and that what the radiologist is reading is not inherently a problem, because a lot of times what people come in with is a list of 7 diagnoses, and it says I have AC arthritis, it says I have a labral tear, it says I have severe tendinopathy within my tendon. These have to be the equivalent to a fracture that needs to be fixed. And I'm a simple orthopedist, and I love when things are a fracture that needs to be fixed. But rotator cuff abnormalities and MRI abnormalities in general, particularly within the shoulder, are clearly not that. And I think that's really what these studies show you, is that the amount of symmetry is common, and how often it's actually predictive of being a painful shoulder with any of these abnormalities is relatively rare. And so labral tearing, tendinopathy, ACOA, a lot of the things that we often address at the same time within surgery, or sometimes we'll even use as independent predictors or indications to do surgery, absolutely can be pain generators. I have absolutely done scopes where I've done a distal clavicle excision or only addressed a biceps tendon and significantly improved somebody's pain. But I'm, 1, far less aggressive with that. 2, always start with non-operative treatment for that stuff. That's not a mechanical problem that has to be fixed for your shoulder to work normally. That is something that we can address if it continues to be an issue in spite of trying all these other conservative things. So, big picture, what's the best way to kind of divvy up rotator cuff tears into what's urgent, what needs surgery, and what is very safe to treat conservatively? Because the takeaway from this should not be rotator cuff tears are fake and they don't need surgery. It's that they're common and that some of them need surgery, and we just need to be selective in when we're doing that and who we're treating conservatively. The biggest differentiation to make is degenerative versus traumatic. If somebody had a traumatic injury with an acute onset of pain, tore off healthy tissue that was there before, our likelihood of getting that to heal, ability to prevent that muscle from turning into fat over time, ability to improve somebody's long-term function with their shoulder is absolutely improved if we get to that relatively early. So threshold for imaging, threshold for referring to a surgeon. If somebody had an acute injury, low. If somebody's had gradual onset of pain, has advanced age, then absolutely starting with conservative treatment, maximizing all the different tools that you have in your toolbox from a therapy standpoint is absolutely what we should be starting with. And only if that stuff's not working and somebody is still having ongoing pain and limitation, then there's absolutely a role for surgery with degenerative tears. It's just not our first option. It's not what we should be doing right out of the gate. We're far more aggressive with young patients because we know the natural history of rotator cuff tears is for them to get bigger. So if I see a 45-year-old that has moderate symptoms but a clear full thickness tear, even if they didn't have an acute injury that they can chalk it up to, I will be far more aggressive with that patient because we have good 10 to 20 year follow-up data that shows they do enlarge and it can progress more towards fatty infiltration. And in a 75-year-old, I don't worry about that as much. In a 45-year-old, I absolutely worry about what the next 30 or 40 years of their shoulder looks like. And I think we don't have great evidence for it, but I think we can impact what their natural history is. So this is one of the treatment guidelines from our AAOS, which is the Academy of Orthopaedic Surgery, trying to stratify rotator cuff tears into high risk, medium risk, and low risk. And I think there's some good takeaways that mostly we've talked about here. But low risk, tendinopathy, partial thickness tears, advanced age, so over the 65 to 70 where it becomes more and more common to have that at baseline. Maximize conservative treatment and surgery if you're having persistent issues. And then just going straight to the high risk stuff, acute tears, traumatic injuries, young patients, minimal muscle degeneration, all those sorts of things are when we should be a lot more aggressive with getting people over to surgery and really intervening from a surgical standpoint. So what sort of questions do you guys have? It's clear as mud.
You were thorough.
What's that?
You were thorough. You were thorough.
Thorough.
I have one.
Yeah.
I guess this is, I'm a physical therapist, so very personal question, I guess, but, I have a patient who is in like a motor vehicle accident with, a type 2 slap tear and, moderate to severe tearing in multiple rotator cuffs, and is not having very good outcomes with therapy, but yeah, I guess from like a doctor's standpoint, how would you look at that patient?
Yeah, and moderate to severe tearing or moderate to severe tendinopathy? Because the big question is the tendon intact or not? The tendon can look really different depending on how you weight the MRI, depending on how much inflammation is going on. So tendinopathy is very much a gray area. If it's a true full thickness tear and it was a traumatic event, how old's the patient?
I believe under 35.
Yeah, I mean, a full thickness tear in an under 35-year-old is like a clear surgical indication. Type 2 slap tear, like we saw, almost 50% of people will be read with that. So that's commonly, just like AC arthritis, something that is read in a lot of MRIs, meaning that if we MRI'd this room, half of you would have a type 2 slap tear called on the MRI. So that, again, that can be an issue, and there are specific physical exam stuff that can help augment some of this decision making. Obviously, this is not getting into every little bit of thing that we do to put the whole clinical picture together for somebody, but a full thickness rotator cuff tear in an under 35-year-old is like one of my shoulder mentors from residency would say, that's a femur fracture, we got to fix that. So it's, there are certainly ones that are very clear that need to be dealt with.
Do you play in with the arthritis of the AC joint with that rotator cuff tear versus bicep tendinosis? It's going to have a triadic combination where the pain generator is. If you're really locked up on that AC joint.
Yeah, it's really hard to, there's almost a buffet of surgeries that can be done in the shoulder. And when you're making clinical decisions about what to do, some of it is saying, well, we're going to do what we need to when we get in there, which is some of the decision making with the long head biceps. We're going to look at it, we're going to probe it, we're going to see if it's sliding out of the groove, we're going to see if there's really a type 2 slap tear or whether it just looks like it on MRI. And if there is, we're going to deal with it. The AC joint is something that it's so pervasive that people have pain or have arthritis there on the MRI, and so pervasive that that's asymptomatic, that for me it's 100% a clinical decision unless there is severe inferior osteophytes that I think are contributing. So if I see somebody on an MRI that has severe ACOA to the point that it's contributing to almost a subacromial spur, and that's where they're having rotator cuff pathology, then I almost consider that part of the decompression, is to deal with a bit of a distal clavicle excision and taking off some of the end of the clavicle. But otherwise, I will 100% use direct tenderness to palpation on clinical exam, pain with crossbody abduction, all those sorts of things for provocative stuff for the AC joint to decide whether to do something at the distal clavicle. The biceps I will examine, but there's so much overlap between an O'Brien's and a supraspinatus test, and somebody's acutely painful from a cuff tear. I think you have no way to reliably isolate the long head biceps to stress it, so that is almost always an intraoperative decision. My biggest conversation with patients is, what the heck should we do with it? Should we just release it like we did forever, which is way easier and likely tolerated just fine by the vast majority of people? And Sean Gray, who's one of the highest volume shoulder guys at OCR, had his own long med biceps released, and he's a 6'7" D1 basketball player, and he flashes people his biceps and says, "This doesn't bother you," and so he's able to release everybody because they're like, well, if this guy does fine, I'm going to do fine too. But you know, I think the conversation about tenodesis, whether to do the extra surgical procedure, which is sometimes to anchor in the shoulder, sometimes to anchor subpec, and then you're giving somebody an open incision, all those sorts of things. I think that decision making is the conversation I have in clinic, is not whether their biceps is an issue. I mostly make that as an intraoperative evaluation, but whether to anchor it or whether to just release it is the tack-on conversation in clinic, which sometimes people get so confused by that they forget that they have a massive rotator cuff tear that we're going to fix. And that can be frustrating with the shoulder too, is you end up talking about 3 or 4 different small parts of the surgery when 95% of it is that they fell, they tore off their rotator cuff, they can't lift their arm overhead anymore, and 95% of the surgery is trying to get that fixed. So, yep.
I just want to know your thoughts on, with cuff repairs, tissue healing time frames. Just in your mind of some of the milestones.
Yeah, people are slow with cuffs, and it's different for different ages, and it's different for different size cuff tears. And you probably realize most of us just are conservative with everybody because it's easier to have a single protocol. And if you said, this is a 10 to 15 millimeter, i.e. smaller than a postage stamp tear in a healthy 45-year-old that's going to be load shared with a lot of intact and healthy tissue, there are certainly studies looking at rotator cuff healing with no sling and very progressive rehab protocols where they're letting people kind of do almost activities as tolerated.
On that, with the bioinductive, augmentation.
Yeah.
How do you adjust for that?
What do you mean by bioinductive?
Regenerative.
Regen 10 and that sort of thing? Yeah, so, and that's the Regen 10 is a whole different conversation. But in general, a full thickness rotator cuff tear, most people are cautious. Most people are 6 weeks in a sling without active motion, not wanting to stress the repair. We certainly know that there's some early consolidation, but not full strength, and that most people are 12 weeks before they're really progressively strengthening. I don't think Regen 10 speeds up healing. People rehab faster with Regen 10 because the current indication for it is a partial thickness rotator cuff tear. And so if you are throwing a biologic graft on top of a 50% partial thickness rotator cuff tear, you can be progressive because you're not dealing with a full thickness tear that's being held down with sutures and that sort of thing. So the Regen 10 is with that is a little more rapid. And the Regen 10, for the vast majority, you probably don't know what it is a bovine graft that has been infiltrated with growth factors that is onlaid on top of the rotator cuff and has been shown to have pretty good inductive healing, meaning the rotator cuff tissue will grow into it and it will thicken the tissue. And so the hope was to find something to do for partial thickness tears. There's certainly some people using it outside of the current recommendations, which is throwing it on top of full thickness tears as just something to help. And there's certainly not been long-term evidence of that. I've done a few and had good results with it. I've had a partner that has an MRI of that $1,500 graft balled up under the acromion where it clearly didn't do anything. And so it's hard to know, and it still is relatively early with it, and it's expensive. Like a lot of the kind of newer cutting edge stuff, it's always a matter of You don't want to be the first, and you don't want to be the last. And there's probably somewhere in the middle that's right, and you got to definitely consider the expense in that too. So, all right, I think we hit our half hour.